Hello and welcome everyone to our latest podcast on prevention of early VAP after cardiac arrest, the ANTHARTIC Trial. Although TTM is recommended in out-of-hospital cardiac arrest with initial shockable rhythm, it carries the risk of secondary infections. Hypothermia constitutes an independent risk factor for early VAP. Protective effect of intravenous administered cefuroxime against nosocomial pneumonia in patients with structural coma was done in 1997 by Servant. This was the first study looking into this. Subsequently, Acuro et al. Conducted an RCT in Brazil in 2005 with prophylaxis of ampicillin sulbactam and found benefits of antibiotic prophylaxis. Then Valles et al. Did a prospective non-randomized trial in 2013, which was followed up by two retrospective analyses by Davis et al. And Hallenkamp et al., showing benefits of antibiotics prophylaxis. So this group hypothesized that systemically administered of empirical 2-day antibiotic therapy would prevent early ventilator-associated pneumonia and related complications in patients with out-of-hospital cardiac arrest. The study was designed in France. It was a double-blind, placebo-controlled, randomized controlled trial. In the intervention group, the patient received 1.2 grams of amoxicillin clavulinate IV 8 hourly for 2 days and control received normal saline as placebo for 2 days. The primary outcome was early VAP, that is 7 days, adjudged by a 3-member blinded intensivist committee. The committee only reported cases with pathogen documentation in the primary outcome. Secondary outcome, the late ventilator associated pneumonia, that is after 7 days of hospitalization. Other nosocomial infection, that is bloodstream infection and urinary tract infections. Mortality at day 28, intestinal acquisition of multi-drug resistant bacteria on day 7. The sample size was calculated based on 68% incidence of VAP and a 25% estimated reduction. 163 patient with 90% power and type 1 error of 5%. Death as a competing factor, the sample size was increased to 192. So 1116 patients were assessed, 198 randomized and 194 analyzed. The primary outcome shows early VAP of 32 cases in placebo group, 19 in the trial group. The secondary outcome shows 41% mortality in the intervention group while 37% in the control group. MDR acquisition was nil, ICU length of stay was similar, ventilator free days was similar, but there was significantly more antibiotic free days in the intervention group. So the authors concluded that antibiotic therapy with amoxicillin clavulinate in patients receiving 32 to 38 degrees centigrade resulted in a reduction in the incidence of early VAP than placebo. So the strengths are multicentric double-blinded design, committee-based assessment of VAP, diagnosis, limitations, underpowered study because the sample size was calculated based on 68% incidence, whereas actual incidence in the study was only 29.4%. Questionable hypothesis how amoxicillin clavulinate with a half-life of 8 hours could have effect lasting for up to 7 days. Diagnosis of VAP was made by only culture positive cases. The study findings cannot be extrapolated to in-hospital cardiac arrests and non-shockable rhythms. How will it change our practice? In an Indian scenario where the EMS systems are still in their infancy, out-of-hospital cardiac arrest with shockable rhythms, resuscitated well, and arriving in an hospital is a very rare finding. So this will not affect our practice.